So a very good morning to everyone. I, Dr. Poonam Joshi, welcome you all to our another class of ACTREC Head and Neck academic session. So for today, our speaker is Dr. Nitin Shetty. Dr. Nitin is head and professor in Department of Radio Diagnosis, ACTREC TMC Mumbai. Dr. Nitin will be speaking on the topic role of interventional radiology in the management of head neck cancers. So I welcome Dr. Nitin. Dr. Nitin, we can see the PPT. Yes.
Thanks. Good morning, Poonam. And thank you so much, for giving the opportunity to talk about the role of intervention in head and neck cancers. Now, I'm not sure how many of the students would be aware that the role IR plays in the management of head and neck cancer. So what I will do is that there are pretty much, one second. Yeah. So this is how I would cover the topic. This topic essentially I had done for for the radiology residents. So there are a lot of technical details that were included, which I have removed, but pretty much the scope even for the surgical resident would remain the same. I'll just do one thing, Poonam. I'll just switch off my video so that I don't have problem with the bandwidth. Are you able to hear me properly, clearly?
Yes, we can hear you, Dr. Nitin.
Okay. So essentially, but the role begins with the biopsies. That is where the bulk of the work in the head and neck cancer starts with the biopsies. The biopsies where you do comfortably, it is done under direct visual, under direct vision, and which are deep seated. It is referred to for IR. And then comes the vascular intervention. Some electively we do the vascular intervention, sometimes emergency. And then I'll just close with by talking about the non-vascular intervention that we do. So this is pretty much straightforward for the surgeons. You see the tumor and then you biopsy it. But what about these lesions, those which are situated deep in the skull base or near the pterygoid fossa, or involving the bone? This is something that is inaccessible for the surgeons because it is not seen, and this is where under image guidance we can do the biopsies safely. And broadly, if I have to say what are the indications for image guided biopsy in head and neck tumor, it is those masks which are not palpable or nodes which are not palpable situated deep, like I mentioned now. In cases of known head and neck cancer where biopsy is done, but the nodes is not very convincing. This is another place where the biopsy is normally requested. Previously, FNAC is normally the modality to confirm the presence or absence of metastasis in the node. But if at all, if FNA is coming repeatedly negative, at that time, the next option is to go for a biopsy because we can give more course and better yield can be given by the pathologist. Subsequently, after the completion of treatments, be it surgery or RT, if there is any recurrence, then again to confirm histopathologically, we do a biopsy. And parotid and submandibular masses are another region where we prefer to do biopsy over an FNAC. So there are multiple modalities that are available. It can be ultrasound or CT scan. Sometimes we use a combination of both ultrasound and CT scan. And I'll show you some examples where fluoroscopy also has played a role to do a biopsy of in the head and neck region. So the indications for CT guided interventions, it can be deep seated lesion. Now we discussed about in general where the role of ultrasound and CT was, but here and specifically the indication for CT guided biopsies are those lesions which are more than 3 centimeters. Here ultrasound would not help us. Orbital lesions again, because there is a very limited penetration in the ultrasound. When we are using CT scan, we are much more safer while targeting the orbital lesions. Those patients which have got inadequate mouth opening and the surgeons are not able to take the biopsies, again, ultrasound would not be the modality. This is where CT scan is used. Post-op recurrence, because of the limited window that is available on ultrasound, again, CT is a better modality. And when multiple biopsies are coming negative, even after doing it under direct vision, that is when we take a deeper biopsy using CT guidance. Now, this is just in the planning. We for our resident, this we stress that it is important that we see the biopsy, the pre-biopsy CT or MRI, and accordingly give the appropriate position for the patient. And always we use IV contrast so that we identify the vessel and we are able to target the lesion safely. By and large, the biopsies are done under local anesthesia, but at times, especially when we are using a difficult approach, like a transoral approach, or in pediatric patient, we use the general anesthesia. Broadly, the approach can be either suprahyoid or the infrahyoid. When we are talking about suprahyoid, the various approaches we have is subzygomatic, paramaxillary, retromandibular, transoral, and posterior approach, especially when the lesions are located posteriorly. Infrahyoid, we have anterolateral and posterolateral, again, depending upon whether we go anterior to the carotid space or posterior, and then posterior approach. So quickly moving on to the various approaches that I mentioned. So this is a subzygomatic approach where the needle is passed below the zygoma, and you can see here there is a mass in the masticator space, which is very easily targeted. So this is the area which can be covered, pretty much the parapharyngeal area, the masticator space, the pterygoid bones, all these areas can be targeted by subzygomatic approach. And the next, moving on to paramaxillary, going in between the mandible and the maxilla, here you can see a mass which can be targeted by the paramaxillary approach. Again, IV contrast, we identify the facial vessels and then avoid those so that there is no injury. Next is the retromandibular approach, wherein we go behind the mandible. Again, we identify the vessels and then avoid those vessels to reach that area, which cannot be targeted by either paramaxillary or the subzygomatic approach. Now, as we go deeper and more close to the midline, we need to be more careful. These are the cases which we do under GA. So the area targeted is the clivus, the C1 vertebra, the C2 vertebra, the retropharyngeal space, the prevertebral space. All these areas are covered. So this is how we go by the transnasal approach, that is via the nose, and transorally. So this is all the segment that we are able to cover. So starting the skull base, clivus to almost C2 vertebra, we are able to cover by this approach. So this is an example of the transnasal approach. This is something, the head and neck, location, the tumor is involving the C3 vertebra posterior elements. In this, the approach to the lesion would be directly from posterior. Now moving to the infrahyoid neck, again, it can be anterolateral or posterolateral. So here you can see this is the anterolateral approach. So it is essentially anterior to the carotid vessels, the carotid space. So it can be again via the thyroid. It can be just lateral to the thyroid, as in this case, or it can be between the thyroid and the tracheal space. So these are the various approaches we have through the anterolateral approach. And posterolateral is when we go behind the carotid space. So here, these are the examples. This is how we approach posterolaterally. So any mass located in this location or the vertebral lesion can be approached by these two methods. So similar to suprahyoid, when the lesion is involving the pedicle, the approach would be essentially from posterior approach. Now, quickly, I'll just move on to the cases. Here you can see follicular lymphoma, which was on treatment. This is an example for orbital biopsy. Similarly, even head and neck primary case involving the orbital region, we can safely do the biopsy here. We know exactly where the optic nerves are, where the vessels are, and we can safely avoid those critical structures when we are doing it under CT scan guidance. And in this case, it was high-grade B-cell lymphoma. This is a 71-year-old lady who presented with loss of vision, and imaging it shows the skull-based tumor involving this sphenoid bone, a large tumor here you can see, and this is the zygomatic process. We go subzygoma, And this is how we plan to go and target. You can see the vessels over here. It can be avoided. And the histopathology turned out to be follicular architecture, likely primary. So after the biopsy of this, we did the ultrasound of the neck and we found that there was a thyroid mass. Patient underwent thyroidectomy and followed by RT to the sphenoid wing metastasis. Similarly, again presented with the known case of CA breast on planning PET. There was an FDG avid lesion involving the greater wing of sphenoid. The CT guided biopsy, again subzygomatic approach. It was targeted. You can see the soft tissue component as well as the destroyed bone. These were targeted, and it came out as the synovial sarcoma. So that was a second malignancy in this patient who had CA breast. So this was another interesting case, a 60-year-old male who presented with the sudden loss of vision. And when the patient underwent MRI, they found that there was a giant aneurysm in the cavernous ICA. So we assume that the cause of the loss of vision would probably because of the compression of the aneurysm, compressing the optic nerve. And so the patient underwent uh, the coiling of the aneurysm. And despite the coiling, the patient did not have any improvement in symptoms. So when we went back to the MRI, we saw that there was a soft tissue component that is causing destruction of the clival bone also. So this was there. It was initially subtle, but then post coiling, when it did not, when the vision did not improve, a repeat MRI showed that there was increase in the soft tissue component. So here transnasally through the nose under fluoroscopy, we reached the site where it needs to be biopsied. So the fluoroscopy is extremely important because anything we go deeper, we would straight away hit the brain. So we need to under fluoroscopy exactly identify the region where we need to biopsy, and the combination of CT and fluoroscopy gives us the confidence. So the final histopathology turned out to be a prolactinoma, and he was referred to an endocrinologist for further management. Another patient of this, you can see there is destruction of the C3 vertebra. So the initial suspicion was some metastasis, which is causing the collapse of the vertebra. Another, again, under fluoroscopy, we targeted the destroyed vertebra, and the histopathology came out to be granulomatous inflammation, negative for TB, but it showed streptococcus, and patient was started on treatment accordingly. Now, a case of CA nasopharynx, it was treated post CTRT, and in follow-up, the patient developed some pain, and PET CT showed that there is an avid lesion in the basi-occiput region. Recurrence was suspected. In this case, it was straightforward approach it by posterior approach, and the final histopathology was negative for malignancy, and it was mostly post-RT changes. Now, at times, we do get to do the biopsies from the vocal cord. These are especially those cases wherein the repeated DL biopsies are negative. So at those in that setting, we do a PET scan, identify where the avid lesions are, and based on the avidity, we can exactly target which area needs to be biopsied. As in this case, the avid area in the anterior commissure, it was targeted, and it turned out to be squamous cell carcinoma, and patient has been planned for salvage laryngectomy. So one of the advantage that we have in our setup is the presence of rapid onset evaluation, what we called as ROSE. So as soon as the biopsy is done, we give the specimen to the, prepare the slide and give it to the cytologist who would be there, and they evaluate the adequacy at then and there. If they're able to report on that slide, we take multiple cores from that area. If they say that there is no representation, then we redirect the needle so that better area is targeted. So overall, because of this, the yield is much higher, and the repeat need for repeat biopsy, repeat FNAC significantly goes down. So this is we pretty much do all the biopsies and FNACs under using ROSE. Now, moving on to vascular intervention, one of the common vascular intervention we do is a balloon test occlusion. So, balloon test occlusion essentially it is done for those tumor which is very close to the carotid artery, and where the surgeons feel that there is a risk for carotid injury on table, and they might have to sacrifice the carotid artery in case if there's an injury. So any situation which warrants ligation of carotid artery on table during surgery, we do a BTO. So what exactly is BTO? BTO is a balloon test occlusion or balloon occlusion test, wherein that artery which we are going to sacrifice or at which is at risk, it is temporarily blocked using a balloon, and then we demonstrate that from the contralateral carotid or from the vertebral artery there is circulation which goes to the brain. So essentially we are evaluating the adequacy of the circle of Willis. So I'll just show this with an example. So this is a 36-year-old lady diagnosed as left maxillary adenoid cystic carcinoma in 2012, underwent maxillectomy, developed recurrence after 6 years, and after a year again because of the increase in the size, lost vision, and surgery was planned. Here you can see that's a huge mass and pushing the eyeball to the opposite side. And here it is in close proximity to the left carotid artery. So the surgeon wanted to know whether there is adequate cross flow in case they had to ligate the carotid artery because of injury. So you can see here there is a vascular lesion. There is an intense blush, and what we do, we take a balloon. Here you can see this is a balloon. We have taken it in the carotid. We have inflated the balloon. So this is the balloon which is inflated, and once it is inflated, we quickly do the angiogram of the contralateral. Here you can see that there is robust supply coming from the ACOM. You can see here the left side is also being supplied. So essentially means that the patient would tolerate any ligation of the carotid on table. So next procedure, the type of procedure we do is angioembolization. So angioembolization essentially means blocking of vascularity. So or tumor devascularization. This is what we call. Um, Now the indication for angioembolization is any vascular tumor or in the head and neck region. Uh, why we do it? For the simple reason, once we devascularize the tumor, it becomes easy for the surgeons to operate. You would prefer to have a bloodless field, and this is where we help by devascularizing the tumor. Sorry. So the procedure is done under local anesthesia or conscious sedation. The reason why we do it under anesthesia is because we can monitor real time as to how the higher mental function of the patient is. So we are all aware that there is dangerous anastomosis between the ECA and the ICA. So the internal and external, there are communication, and these dangerous collaterals, it can result in the embolizing material going from the ECA branches into the ICA branches. So we continuously keep vigil even on angiography to see whether the particles are moving, going to the ICA territory. And also by continuously talking to the patient, getting real-time feedback from the patient, we can assess that we are doing the procedure safely. Now, one of the important thing is how we embolize. So we go as close to the tumor and embolize, so that this would reduce the risk of non-target embolization. So the chances of the devascularization of normal structures like the muscles or the skins, these are avoided because we go as close to the tumor as possible and embolize. Do we need to do complete embolization? No. Even if we do 80% devascularization, that is good enough for the surgeons to operate with less blood loss. But what is important is we need to embolize the tumor bed. We need to understand there is basic difference in how to control the tumor by surgical way and by IR ways. now there is a source in the head and neck region, which is a tumor. That tumor is hypervascular. Now this hypervascular tumor will get blood supply from many arteries. So the first reaction for a surgeon is, whenever there is bleeding from head and neck tumor, is to go inside and ligate the carotid artery and or the lingual artery, if it is the bleeding from the tongue, if it is accessible. But what essentially this does is it blocks the main route. So once you block the main route, it does not essentially mean that the bleeding would stop. So you ligate the external carotid artery, it will anastomose. Like I told, there is anastomosis between ICA and ECA. Now the tumor will start drawing blood from the ICA feeders. The tumor will start drawing blood from the contralateral ECA, from the contralateral ICA. So instead of one straight artery, which we could have used to go and embolize, now it will start recruiting from many other arteries. So it's very important to understand that just blocking the main artery. So it's the same even for intervention radiology. That's what I told. If there is a bleeding from the branches of internal maxillary artery, we need to go into the IMA and block those feeders. We should not block the external carotid artery. So always we have to block the tumor bed, not the main artery, because it will always collateralize and there will be it will continue to bleed. So when is the best time to do it? It's essentially 48 hours. I think over a period of time we have realized, we started off with the previous day embolization, then we started giving a day extra, and with the trial and error basis, even we have realized in our setup that 48 hours after embolization is a good time to go inside and operate to have the best embolization effect. So these are just examples where we have done angioembolization. Again, the tumor devascularization can be done in two ways. This one of the way is going through endovascularly via the arteries and then embolization. These are the examples where we have gone via the arteries and embolized. Here is the hypervascular tumor, glomus tympanicum, which was selectively cannulated and embolized. This is a post-tumor. There is a significant reduction in the blood. Patient underwent surgery with 600 ml blood loss. Similar case, hemangiopericytoma, post-surgery, post-RT of the petrous bone, there is recurrence. We can see an intense blush. Here also, endovascularly, we identified the artery which is supplying the tumor, selectively cannulated that, and we embolized, and post-surgery patient had around 800 cc of blood loss. So that is one way endovascularly to devascularize. The other way to embolize is percutaneous. So like I told, ICA, we can go inside endovascularly and safely embolize. But sometimes we get supply from the ICA. So ICA, here you can see this is the internal carotid artery and supply is coming from the ophthalmic artery. So when we are embolizing endovascularly, ICA is not a good location, because there is very high chance that these particles will reflux into the brain and cause stroke. So the territory that is supplied by ICA, we approach by the percutaneous method. So how we do it? Essentially, we have got various way. We either go through the nose or the oral cavity. We put a needle, and under fluoroscopy, we exactly target where it has to reach. So here we can see that transnasally we have inserted the needle. So this is where the tumor is. And these are the coils that we have placed after embolization. And under vision, we just inject a liquid embolic agent. So we call it as blue or onyx. So this is the liquid embolic agent. It will just percolate along the arterioles and over a period of time fill it up and completely devascularize. So this is a percutaneous way of tumor devascularization, especially done when there is significant supply by the ICA territory. So this is a case of, again, JNA, a large tumor which involving the entire right nasal cavity and protruding out. And in fact, he has multiple episode of epistaxis and has difficulty in breathing. He breathes through mouth. and CT scan showing large mass. Again, the entire nasopharynx, the nasal cavity on the right side is involved. The MRI shows brilliantly enhancing lesion. You can see that there is hardly any nasal cavity seen, everything pushed to the other side and extending down into the oral cavity. So this is the extent, and highly vascular. Definitely in our setup, we do devascularization. Again, the lesion was close to the IC. Here you can see that practically the IC is not seen at all, completely pushed and encased. So we did a BTO. We confirmed that there is good cross circulation. Then endovascularly, we went inside and embolized all those arteries which were supplying. So the external carotid artery supply was essentially taken care. And after that, we prepped the patient for the direct puncture angioembolization, tumor embolization through the nose, through the mass. We introduce the needle, you can see here, and subsequently after injecting sufficient glue, this is the final cast. So this part was supplied by the ECA, which was taken care by angioembolization. The rest, which was supplied by the ICA, we took care by direct puncture embolization. So this is end result. This is how it was, the devascularized tumor, and this patient had a blood loss of 500 cc. So on MRI, it was extremely hypervascular. So the patient had just a bleeding of 500 cc. So another quick case where the multi-modality approach is taken. So now at this point of time, I would say perhaps we can have an expert the opinion from Poonam or other consultants who has joined at the end. One of the feedback that we received from the surgeons is that when we use glue, like this case, it becomes hard to remove. Like if we do only ECA embolization using particles, it becomes soft and easily comes out. But this glue essentially it hardens the tumor because it solidifies, it hardens. So removing it endoscopically it becomes difficult. And another drawback is that as we go close to the bone, you would not know whether you are actually removing the tumor or whether you are removing the normal bone. Again, there would be some confusion. So at times the surgeon says that not to go ahead with percutaneous embolization or not to use glue. But again, it is the surgeons can tell you best. So this is one case wherein we were asked not to do the ICA embolization. So again, GNA recurrence. So this was the ECA component, and this was predominantly supplied by the ICA. The BTO was done, so this was supplied by ECA. So this is how a DSA image looks like. DSA is digital subtracted angiography. Everything is subtracted, the bone, the soft tissue, everything. And only thing that we see is the contrast that we are injecting. So this is the clarity that we get. So the lower one is post embolization. You can see that there is significantly reduction in the blood flow. But ICA, there was quite a bit of supply from the ICA. But then we did not go ahead with the percutaneous embolization. But on table, the mass was adherent to the ICA and it continued to bleed. So the patient, the surgery was stopped. It was shifted down to DSA. You can see all the packs put over there to block to stop the bleeding. And then in the DSA, we identified the tumor, and which was residual tumor. We punctured it directly and then embolized. And also, because it was adherent to the carotid artery, we also coiled the carotid artery so that there would not be blood loss because of carotid injury. And finally, the resection of tumor in toto could be done. And it was so vascular, despite embolization, there was a loss of 1300 ml. And prior to that, just without when they started removing in the ICA territory itself, there was 1200 blood loss. So, but the point is combined percutaneous angioembolization and percutaneous embolization and also endovascular embolization, a good devascularization is possible. And doing a balloon test occlusion will further improve the confidence level of a surgeon to handle any carotid injuries. Um, but yes, not always. This is another in our initial days when the carotid tumor was not embolized. We were called intraoperatively. So on table, we had to puncture the tumor and embolize this. This was done in the OT. You can see a very small C-arm. The bones are overlapping, and we are not able to identify the exact flow of the glue. And so this is a disadvantage. So that's the reason why we prefer to do the embolizations in under DSA setup rather than under fluoroscopy in the OT. Now, that's not the only time that we do angioembolization. Sometimes when the patient presents with the tumor bleed or post-operative the injury to the vessel or post radiotherapy vascular injury, even they present with massive hematemesis or bleeding orally. So in this case, this was the post CTRT base of tongue tumor, and there is a second primary from the left PFS. And here we can see that there's an outpouching of the left carotid artery. There was profuse bleeding per oral and suspected a carotid blowout. And here again, reconstructed image shows that there is a nipple-like projection in the left CCA. Again, the treatment is quite simple endovascularly. You do the angiogram and you put what is called as a covered stent. So covered stent is like a regular stent which has got a Dacron sheath. What you use or call as graft, it is a similar thing what we call as stent graft. So it prevents the blood going out of this stent, and at the same time it removes the aneurysm out from the picture. So the blood flows directly from the through the graft into the ICA. So this is how the post angiogram looks like. So from the stent graft, the pseudoaneurysm is excluded, but we have got good supply to the ICA. Not all the time we will be able to save the artery. At times, to control the bleeding urgently, we might have to do, we might have to sacrifice the artery. So that is called a parent artery occlusion. So this is just an example of that case where it presents with the massive, because it's bleeding from the carotid, there is a massive bleeding. And at the end, when everything is controlled, you see that the hole is very small, but potentially it could be a life-threatening bleed. And in these situations, I think our surgeons would agree, it becomes very difficult. Post-RT setting, it is like a frozen neck. It's difficult to go in and control the bleeder. So in such situations, endovascular option would be the best. So another post-op bleed, this is a case of JNA and planned for excision. The surgery went on very well. He underwent BTO he tolerated. So after endoscopic excision of the tumor, there was just 2 liter blood loss. He was shifted without any uneventfully to the ward. But on 5th post-op day, he had a profuse bleeding. He collapsed in the ward. He was shifted to IRC in BP of 40/80. So this is the blood loss, the bleeding that was going on. And with this, we just performed a CT scan. We have got a machine wherein CT and DSA are integrated. So we did a CT scan. We could see that there is the entire cavity which was resected is filling with blood. So we took for angiogram. So you can see that there is a blowout from the ICA. The entire cavity is being filled. So it's just within 5 minutes, once we are there, we go inside and we occlude the artery and the bleeding stops. So it's a massive bleed, but we can achieve embolization within matter of minutes. And post parent artery occlusion, you can see that there is supply from the to the contralateral hemisphere. So the brain also was saved, and the patient after a couple of days was discharged without any incident. Here again, I would like to stress the importance that doing BTO not only gives confidence to the surgeons that the carotid can be ligated, it also gives confidence to us in case if we have to block the carotid, as in this particular case post-op when we had a bleeding. Now, okay, so it's almost 10. So another 15 minutes, I will quickly go through another indications which is coming up in the region of head and neck. And then for the last 10 minutes, we can just keep for any discussion related to the topic. In general, the thyroid RFA, it began with a treatment of for benign thyroid nodules. Over a period of time, it gained, it was a successful, especially in Japan, Korea. It was started off for cosmetic reasons. Then it was expanded for autonomously functioning thyroid nodules, wherein the surgery a patient wanted to avoid surgery. But seeing the success for benign thyroid nodules, the indication started expanding to the malignant subset. Essentially, started treating thyroid cancers. Now, uh, as we have learned in the last few years, we are able to safely perform thyroid RFA even for in a malignancy. By and large, there are definite indications for thyroid RFA in the cancer setting. Um, mm, Most of the time, it is by patient's choice. The patient would not want to undergo surgery for their own reasons. And if there is an option wherein surgery can be avoided, they wish to take that. It's not all the patient, but a few of them. And again, active surveillance is one of the option for T1 tumors, but then sometimes the patient might have anxiety as to whether that would increase in size and cause problems. So those patients wherein active surveillance is an option, is an area where we can explore using thyroid ablative methods. When we would want to do, sorry, when we would want to do ablation, that's again, it's an evolving field. We would, when we compare surgery to thermal ablation, surgery has been for a very long time, and it is the modality of choice for any type of tumors, and it is pretty much the gold standard. As compared to that, in the ablation, what happens is the cost of surgery is less. The complication rate are less because it is extremely very minimally invasive, and post-op the quality of life is again better. All these things are because it is an organ preserving treatment. We would essentially leave the thyroid behind and treat only the tumor. So overall outcome in that case is better than surgery. But again, that is a very small subset which we can treat by ablation, and not everything that comes is for RFA or microwave. Um, Now, when we see definite indication in thyroid malignancy, for the thyroid gland per se, it is the papillary thyroid microcarcinoma, that is essentially T1A, which is T1A and few T1B also, which has been treated by RFA. And those patients where thyroid resection is not possible, unresectable, but patient has having symptoms because compression on the trachea. So that is another area where RFA can be done to cause debulking. Third area is recurrence after surgery. So those nodes can be treated by RFA. And patient who develop distant metastasis, but yes, oligometastasis, patient is having symptoms, even those can be treated by RFA. Now, coming to treatment of thyroid gland malignancies, the indications are essentially T1A, that is if the patient requests treatment, who is otherwise under active surveillance. T1B, if patient is unable to tolerate or refuse the surgery. These are the only prime indications for PTMC, in case of papillary thyroid carcinoma. And anything above that, T2 and above, would be only in select patient situations. So otherwise, surgery would be the gold standard. Now, this is a case where this was our first case that we did in TMH, where this is a case of papillary carcinoma thyroid underwent total thyroidectomy, bilateral neck dissection, and central compartment clearance. After 3 years, developed a small nodule, we can see here, which is just anterior to the trachea. Again, it was referred because it was a solitary nodule. It was referred to attempt RFA because the patient as well as the surgeon wanted to avoid surgery. Before doing ablation, we definitely confirm it by histopathology. We do an FNAC, and in this case, it showed deposits of papillary carcinoma thyroid. So under ultrasound guidance, we identify where the nodule is. We do the procedure under local anesthesia. Doing local anesthesia, one is that the GA is avoided. Secondly, with local anesthesia, we are able to give sufficient hydrodissection. That is, we are able to dissect out the arteries, nerves, and the critical structure, like in this patient, the trachea, away from the zone of ablation, so that these critical structures don't get damaged. So here we have separated out the trachea. We have pushed the trachea behind because by hydrodissection, introduce the needle, and once the ablation starts, this is what it's seen. You see a zone of hyperechoic, or the white zone is called hyperechoic. Which means that that's the area which has undergone ablation. Then we come back and ablate the other remaining zones. So this is moving shot technique is what we call. So we burn it, come back, burn it, come back, so that the entire zone is ablated. So the follow-up, this is pre-ablation, it could see the enhancement, and this is post-ablation. After 3 months, there is no ablation, and even the patient tumor markers are also under limit, and he is under observation. So that was the case, first case which had come for recurrence, and now this is a second case which we did at ACTRAC actually. She was a known case of malignant melanoma rectum. She underwent surgical the surgery, and in the follow-up surveillance PET scans, it showed FDG avid nodules in the thyroid. So the melanoma was under control, but thyroid showed uptake. Ultrasound showed bilateral sub-centimeter suspicious lesion. FNAC done turned out to be papillary tumor. Again, the patient was very clear that she, being a singer, she does not want any damage to the nerves, and her voice should not change. So it was referred for surgery. And again, under ultrasound guidance, we were able to target. This is the carotid and the vega and the laryngeal nerve. This is where it would come. So we put this is the hydrodissection being done so that we can separate out the tumor. So you can see that saline is being injected. That's a tumor. And once we get sufficient safety margin to do the ablation, then we go inside and perform the ablation. So this is the burst that we seeing after the ablation, the hyperechoic zone, which gives us the confidence that the entire ablation of the tumor nodule has taken place. And now in the this is how this scar, there is absolutely no scar, just one mark where we have put the needle. And in this patient, post procedure PET scan which showed avid lesion had completely disappeared. So this was an avid one, and here you can see that there was there was complete disappearance of the avidity. So there is no avidity at all in this lesion, which was seen previously. Again, there are multiple reports which says that ablation can be done safely even in case of malignant thyroid nodules. And this is one of the paper in 22, which studied retrospectively 847 patients with a mean follow-up of 22 months. It shows that there's a complete disappearance of tumors in 68% of the patients, T1A group, and 64. So almost 2/3 of the patient in the follow-up of 22 months had complete disappearance of the tumor. So the overall complication rate was less than 5%. And this concluded that thyroid RFA is safe and effective for T1 M0 M0 papillary thyroid. Another paper which was published last year, again which had a follow-up of 5 years. So they evaluated 358 patients, and in the period of 5 years, the overall disease progression was 5%. The incidence of lymph node metastasis in these 5 years were just 1.4%. Recurrence was around 3%, and persistent tumor was less than 1%. So in their series, they did not have any complication. And when a T1A and T1B group were compared, there was no significant difference in terms of the outcome. So disease progression was again almost 5%. Lymph node metastasis also 1.3, 1.8. And recurrent tumor or persistence of tumor, none of them had any difference when it came to T1A or T1B group. And 5-year recurrence-free survival at 5 years, it was 95% and 96% for one T1A and T1B. So good survival rate. And none of the patient in their series had to undergo surgery because of anxiety. So even this paper, it concluded that it is safe and an effective alternate for T1M0, M0 PTC, and it can offer a minimally invasive curative option for those patients who do not want surgery or who were anxious about active surveillance. Now, moving on to the last topic, this is done very sparsely, I would say. So this is perhaps one of the reference that we got for persistent Chi leak after intervention, after post surgery. So this is a case who underwent CA buccal mucosa, underwent left heavy mandibulectomy and left neck node dissection. Chylous output through the neck. Here you can see there are a lot of clips that have been put in the left supraclavicular area. Potentially, probably that's the site from where the lymph would be leaking. And on CT scan, we see a collection and the drain is gone through that. So because it was not being managed on conservative line, the patient, it was referred for intervention guided for treatment. And now the first step in lymphatic intervention is to do a lymphangiogram. So how we do lymphangiogram is we identify a node in the groin and then inject material called lipiodol. So lipiodol is viscous material and radiopaque. So we exactly know how it is flowing. So this is how the lymphatic system is getting opacified. Then we trace it up. We see the lymphatic, then this is the thoracic duct, and this is where the cisterna chyli is. So cisterna, we trace it up. We make sure that to see if there is any leak en route from the cisterna chyli via the thoracic duct into the termination where it terminates at the junction of the supply vein and the jugular vein. So we trace it over there. So even in the CT scan, we just make sure that to identify exactly where the site of leak is. And in this particular patient, at the end of the procedure, we did not find any leak going into that particular cavity. So when we don't find on table, what we do is that we repeat the CT scan on the next day. So in next day, at 24-hour scans, we could see that lipiodol which we had injected the previous day is moving towards the collection. So we could see some lipiodol that is coming out of the duct and then it is collecting in the cavity. So most of the time, because the lipiodol is quite viscous, the simple process of doing a lymphangiography itself will seal the leak most of the time, and we do not have to do any embolization. But if the leak does not seal off after lymphangiography, then what we do is that we puncture the thoracic duct and then we do embolization, very similar to how we did angioembolization for the tumor from the arteries. The similar way we would do for thoracic duct. So, but this was the first patient whom we did lymphangiography, and the patient responded with lymphangiography alone, and we did not have to do any thoracic duct embolization. So this is the scope of IR in head and neck embolization. So we have pretty much covered the biopsies, the vascular interventions, and thyroid ablation, as well as little bit of lymphatic intervention. So thank you so much for the patient hearing, and Dr. Poonam, you can add just any surgical aspect, if anything that is left from my side, or anything you want me to clear.
Great lecture, Dr. Nitin. I think this was to basically for the students to tell them that there are so many applications of interventional radiology in the management of head neck cancers. So it was a great lecture, very comprehensive, and you touched upon almost every point every important application. I think it starts from the biopsy, like you said, the ITF biopsy is where we don't know what to do. Many times we don't know the deep-seated lesions, what to do. We can't go beyond the orbit. We can't remove the eye and take the biopsy. So it really helps the surgeon in making the decisions. Moreover, we have so many patients who have diffuse bleeding from the tongue regions or from the primaries. Again, we don't know what to do. We can only ligate the ECA. But then again, the role of interventional radiology comes where you selectively this embolize the bed of the tumor, and it is so selective that it stops. So I would say
that is an important message, Dr. Poonam, that I want the students to understand. If there is an option of IR embolization, that should be the first thing. In fact, you would agree that in ACTRAC and TMH, now the first line of management for a tumor bleed is actually IR and not ligation. If IR fails, then you go for ligation for the simple reason, because once you ligate the artery, then we cannot do anything endovascular. So this is what you're telling
I
is good.
completely agree with you, Dr. Nitin, because I have also over the years seen at TMH itself that earlier we used to ligate the ECA almost always. And then we would have, in fact, the tumor will become more vascular. I think that was because there was everything blocked. It will become more necrotic. It will become more difficult to manage it because it will develop blood supply. It must be having blood supply from so many other areas, not only the ECA. So then it becomes all the more difficult. And over the years, I think down the years, we have seen that almost always we take the help of IR, and almost always we have seen that it gets managed. Not 100%, but majority of the time. So that had been a great help for, especially for us head neck surgeons, especially for our palliative patients also. Many a times they will bleed to death, which nobody wants actually. So I would say there are multiple applications. And then as a resident or student, they should really know that what would be the there is so much of scope for interventional radiology, and we have to work together with that. I think there is one question, Dr. Nitin.
Yes, please.
Can you, is there for RFA, is there any size cutoff for thyroid nodules?
Okay, so when you ask for size, there are two different one. One is for benign and for malignant. So when you come for benign, there is no limit, because obviously it is being done for a cosmetic reason, and we can stage it over a period of time, and we can do multiple sitting. So there is no size criteria when it comes for benign. But malignancy, yes. Now the proven indication has been T1 N0 M0. So anything that is less than 2 centimeter, we can, with a curative intent, we can do ablation.
So, Dr. Nitin, I think there is another relevant question, which is that is it alternative to active surveillance? Because down the years, I think there is paper by Ito et al., and they have a very long follow-up from the Japan that active surveillance is as good as doing surgery. So, what is your take on that?
So we had a discussion about that in the with the DMG also, and we are in the process of jointly doing a trial. Dr. Gauri is leading that, wherein we are identifying those patients who are under active surveillance and giving them the option to continue active surveillance vis-a-vis, and the other arm would be where we do RFA or microwave ablation, and then see the long-term follow-up, how it's going to be. But yes, definitely, though active surveillance can be offered, and though trials have shown that that is one of the best option as compared to surgery, what is unpredictable is the how the patient would consider that. See, among medical fraternity, to say that active surveillance works well is fine, but will the patient accept that? Once you tell that there's a tumor, and even though you say that for the next 5 years nothing is going to happen, that anxiety would always be there with the patient. And if this is just for such patients wherein active surveillance would suggesting that would cause anxiety, we would offer RFA, and let's see what is going to happen. But definitely, yes, that is one place where we are able to, where ablation would actually fit in.
So I completely agree with you, Dr. Nitin, that patients, the psychological acceptance is also important part of treatment. So we may tell the patient, okay, you stay like this, we will be doing ultrasound every 6 monthly, and there won't be much of increase. But we have to understand that probably these patients may not be very comfortable with this concept of active surveillance always. But rather, if you're giving them an option, okay, we are treating you with some treatment which is not surgical, but you will probably have the same survival, that also sometimes patient would be more accepting of that. In fact,
Acceptable, correct.
yeah, in fact, there is a small study from US. In fact, it is from US, and it is that they have asked the surgeons how comfortable they would be having no intervention like this, the active surveillance, and most of them were not very comfortable giving the patient only the option of active surveillance.
The
So
surgeon themselves, they were not comfortable.
yes, yes,
Okay,
yes. So because they had this psychological aspect, then litigation, and so many other things. So
okay.
I think that all needs to be considered when we are considering for active surveillance, especially still in India, where we still the patient may not be actively participating in the decision making, unlike Western countries where the concern regarding the incision in the neck or the treatment is higher. I think so many aspects to it which need to be considered. I think Dr. Nitin, there are a lot of questions. One question: if patient gives pressure to surgeon for surgery for micropapillary carcinoma, then you have to agree to that. So if the patient wants surgery, then we
But
have to agree to that. Patient is the king. You can't convince the patient otherwise. So ultimately, you have to give the patient all the option: active surveillance, RFA, as well as surgery. If the patient, whatever he is agreeing after understanding the pros and cons of everything, we have to go ahead with that. What do you think, Dr. Nitin?
I think if the patient is not willing for active surveillance and request for some sort of treatment for at least for the T1 patients, I completely agree with you that RFA option has to be given. And in fact, if as a surgeon, if you feel that it would be an overkill doing a surgery for a T1 patient, then I think we can in fact offer RFA as the first line option, and then leave it up to the patient. Like for the patient, it is some sort of treatment. They would not say that surgery only has to be done. They would definitely say, I require some sort of treatment. Now the surgeon can take a definitely call that if it is a small tumor which can be RFA'd, I feel that it should be RFA'd. Anything bigger than that which requires surgery should be operated.
Correct. So case selection is important, and accordingly, you have to tell the patient. I think there's one more question. What are the various agents which you use for RFA in thyroid, and the cost? Can we use radio iodine? I think they are asking after that. And secondly, can we use TACE? I think that the agent in squamous cell carcinoma of head and neck region with chemo delivery agents.
Good. That's a very good question, the last one. So let me answer each of them. So now for the RFA, we started off worldwide. It was started off with the radio frequency ablation. So what we call as RFA. So it is one of the modality of thermal based modality for causing ablation. So the other ablative modality is microwave ablation. So both RFA and microwave are good enough, are equivalent in terms of ablating. RFA has been there with us for almost 3 decades. It's time tested and consistent. So, and safety is proven beyond doubt. So most of the people would prefer to do RFA. But now with the improvement with microwave is normally used to give a bigger ablation zone. So, but with the improvement in technology now, microwave also is able to give a smaller zone of ablation, and both RFA as well as microwave, it is being used for ablative technique. Now for RFA, the cost of the needle would be somewhere around 40 to 45,000. That's the size of the that's the cost of the needle. For microwave, it would be another 20 or 25 more, because we have used RFA. I'm not very sure about the microwave cost, but maybe you can just consider around 70, 75. Again, between RFA and microwave, there is not much of a difference, and RFA with the which is priced lesser is good enough. Now, second question is whether radio iodine has to be used. Now, this again has been an ongoing debate with the DMG, head neck DMG. My personal opinion, if there is a recurrence in the thyroid in the anywhere in the bed, then the first for the investigation also we have to first do a radiology study and see whether that's the only site where there is the uptake or whether there is elsewhere also. And if at all if there is elsewhere, then definitely we have to also give radioiodine subsequent for that in for the therapeutic dose. Now, uh, yes, if there is no uptake and the nodes are the only site of uptake after doing RFA, whether it needs to be again followed up with radioiodine, I am not able to answer. I think Poonam, I don't know as a DMG, what is been the conclusion as to whether we need to give radioiodine in such patients. We can just throw some light on that. And to answer the last question, yes, we have put up a study which is in liver tumor, definitely giving intravenous cisplatin versus giving intra-arterial cisplatin, there is a lot of difference. The outcome of giving intra-arterially, the shrinking of the tumor and the side effect is much more less as compared to the intravenous cisplatin. Uh, so most of the liver tumors, it's now moved from systemic therapy to liver-directed treatment if it is limited only to the liver. The same concept has been applied for head and neck malignancy. So inoperable tumor, we can give intra-arterial cisplatin. And in fact, there is a rat-plat trial that was conducted. It was done in AIMS, wherein instead of giving IV cisplatin and following up with the RT, the sessions were planned in such a way that the patient receives intra-arterial cisplatin and subsequently RT. So it had excellent result. We have put up the we had put up similar proposal to our ethics committee. So they have asked justification as to whether intra-arterially we can give cisplatin. So once we give the justification for that, I think we can also have a similar trial done in our institute, and we can come up with prospective study, and we can definitely understand how well it works when cisplatin is given intra-arterially.
So thank you, Dr. Nitin. I think Dr. Nitin, regarding the use of radioiodine, the first question would be that how do we assess that after RFA the nodule has shrunken completely? How do we assess that the nodule has responded?
So the first thing is that what we are doing when we are in our setting, the first patient that was sent had come through a PET scan. So we followed up with the PET scan to see whether there is avidity or not, because the patient was a known case of melanoma. So that was one. Otherwise, for papillary CA, what we are doing is that in the ultrasound, we do a contrast enhanced ultrasound. So the tumor, it shows, it lights up. So simple ultrasound, do a regular ultrasound, then after that do a contrast enhanced ultrasound, identify the tumor, and after ablation we follow it up with the CUS. So if there is tumor, it will show we can see the residual or recurrence because whatever is ablated should not enhance on contrast enhanced ultrasound. So that is how we follow. Also, another modality which can be confidently used is MRI. So MRI, contrast, and CUS, these two will tell us whether the lesion is active or not. So we need to understand that unlike surgery, soon after ablation, the lesion would not disappear. The size would remain the same, but it would be inactive. And over a period of time, so most of these studies that I mentioned, it says that the shrinkage of the tumor starts from 6 months. So the first 3 months, the ablation zone becomes bigger, but after 9, 12 months, over a period of time, it shrinks. So we can follow up with contrast enhanced ultrasound and contrast enhanced MRI both to see the activity of the lesion.
So here I would say, Dr. Nitin, that because we are talking mainly about lesions which are less than 1 centimeter,
Yes.
mostly we are talking about probably the single nodule, not multiple nodule, which I understand is for them, if the RFA is providing the proper treatment, I don't think we need to go for radioiodine, because as per the ATA guidelines also, for a single nodule which is less than 1 centimeter, where active surveillance is an important part, and in fact we are giving a treatment in form of RFA, and it is showing with the help of contrast ultrasound or with MRI that there is no lesion after 6 months or it is stable. I think we need not to give radioiodine. That's my point of view after
Yeah, I think
understanding.
the question was for recurrence, if I'm not wrong.
I think for recurrence, yes, there can be a role. Again, it will depend upon so many aspects, that where exactly is the recurrence, how big is the recurrence regionally also. So I think only saying recurrence, or if that is the only point of recurrence, we again have to see, do we need to give radioiodine, because there will be also cutoff for radioiodine, because they can't be giving it for very large nodules. Usually they prefer small nodules again. So I think that all will come into picture. Then they have to ablate the whole thyroid for that, because they won't be able to ablate only that nodule. So there would be so many aspects. It will be a more of a so many aspects for the radioiodine. So I think it has been a great discussion, Dr. Nitin, and I really thank you for bringing us to our notice and to make us more aware that how useful the interventional radiology is for head and neck cancers. And we ourselves have felt it over the years. So I thank you once again for a wonderful lecture.
Thank you
Thank you
for the
so much.
invite, Dr. Poonam.
Thank you so much, Dr. Nitin.